day, Dr. Daria will give us some good lecture on clinical hematology. Dr. Daria, please.
Thank you so much. Thank you, sir. So today's class is on chronic myeloid leukemia, and none other than Dr. S.S. Daria is being the speaker of this event. He is going to teach the entire faculty on CML. Dr. S.S. Daria is a renowned faculty in the state of Rajasthan. He is a well-known figure. He is an assistant professor in the Department of Medicine and is going to be promoted as associate in few months of time to the senior faculty in the KIMS Medical College, Jaipur, and we welcome him on this platform of clinical hematology. The stage is all set for clinical hematology CML. Welcome, Dr. S.S. Daria.
Thank you so much, sir, Dr. Kamlesh Tiwari, sir, for your kind words, and dear brother, Dr. Amit, for kind introduction. So, friends, today we'll see about the CML. We know that this is a chronic myeloid leukemia is one of the malignancy of blood that which is treatable in last 20 years. So as we all know that there is a myeloid stem cells and a lymphoid stem cells. Through that there is a myeloblast, pronormoblast, and further maturation, then they will get their own cells. So the hematopoiesis is a process where the blood cell lineage are produced by the bone marrow. And in bone marrow, there are the stem cells which capable their self-renewal and the differentiation. So like differentiation means that if it is a lymphoid, if it is a myeloid, then there is a basophil, eosinophil, the neutrophil, okay. And then the proliferation and differentiation of all these cells basically controlled by the molecular signals. And if these molecular signals change, then there is an expansion of your malignancy. So granulocytes will expand to the CML. So in hematological malignancy, we all know that there is a acquisition of growth advantage by a single cell lineage, and the uncontrolled growth results in expansion of that particular clonal population. So the neoplastic transformation basically initiated by either the point mutation, either the another one is a chromosomal loss or a chromosomal duplication or the inappropriate recombination and loss of expression of that gene which inhibits this cell proliferation, and ultimately they promote the apoptosis. So the types of leukemia basically according to the cell lineage, whether they are the myeloid or the lymphoid, and the degree of terminal differentiation. So in acute, there is the progenitor cells with limited capacity for further maturation, and they evolve very rapidly and they require prompt intervention. That's why they are the acute one, either MEB, AML or the ALL. In chronic phase, these primitive progenitor cells with capacity of further maturation, but in acute, it wasn't limited. But now here it is on further maturation, and generally they progress in the indolent manner. If we talk about the particular history of the CML, it starts very long back, almost 200 years back, when Mr. Jones, who described a case of hypertrophy of spleen and liver. Few years back, the Bennett thought that this disease basically represented by an infection. And after that, till the almost 30 years, the Virchow recognized its cancerous nature and he described it as a leukemia. And the next big step came in 1872 when the Ernst Newman recognized that leukemia originated in the bone marrow. And in 1882, the arsenical has been in use for this cancer in the Lancet, particular with the clinical presentation of CML. The big thing in the treatment of CML first arrived in 1982 when I born, because I born in 1982. So the introduction of interferon alpha, which completely cytogenic response comes only in a subset of patients of CML. And in 19, the tyrosine kinase inhibitor, they altered the total landscape of the therapy. And this drug was the imatinib in 1990. And in Time magazine, that time they have written that something magic bullet who can cure the cancer of CML. And first FDA approved this Gleevec by the brand name of Gleevec for the adults and in children in 2003. Later on, there are the tyrosine kinase inhibitors like the nilotinib, dasatinib, and the positinib comes into the picture. So this was the whole story of the CML. It started from the 1845 until 2012. There are 5 kinase inhibitors developed since that. So friends, regarding the introduction, as already told, that these are the heterogeneous group of disease which is characterized by either the infiltration of blood, bone marrow, and other tissues by the neoplastic cell of hematopoietic system, and the dysregulated production and uncontrolled proliferation of mature and the maturing granulocyte with fairly normal differentiation. CML is a clonal hematopoietic stem cell disorder, and if we untreated this CML, then they typically present in a biphasic or a triphasic with an early indolent or the chronic phase, followed by an accelerated, and the terminal last phase is the blast phase. In uncontrolled production and mature of these granulocytes, predominantly the neutrophils, but also basophil and the eosinophil. Clinical course in the chronic phase or accelerated phase and the blast phase. Incidence, if we talk, 15% of all cases of leukemia, whether it is a AML, the ALL, the CLL, the CML, 15% are of the chronic myeloid leukemia. And the annual incidence of this CML is 1.5 per 1 lakh individual per year. If male are slightly higher prevalence of the CML, 1.6:1. The age when we diagnose the CML is around 55 to 60 or the 5th or 6th decade. Yes, it's also in children's nowadays. 3% of patients with CML are younger than the age of 20 years. And the incidence is increasing slowly with the age, with after the age of 40 to 50 years. Etiology, there is no familial association till now for this CML. There's maybe a cause of large dose of radiations. Yes. First, when there was in a Second World War, the atomic bomb were used. So those who were affected by this atom bomb, the people in that population also find the picture of the CML. Exposure to the ionizing radiation, survivors of atomic bomb increase incidence, and no clear correlation with exposure to the other cytotoxic drugs. Pathophysiology. There is a reciprocal translocation between the chromosome 9 and the 22. That is the Philadelphia chromosome. And it occurs, or it can be found out in more than 90% of the patients of CML. There is a fusion between the ABL. The ABL means the Abelson tyrosine kinase gene, that is on the chromosome 9, and the BCR, B for break, P for point cluster. So BCR gene, which is at the 22. So there is a translocation between this 19 and 22. Then they're resulting in a chimeric oncogene, that is a BCR ABL. And the formation of this BCR ABL fusion protein occurs in CML. This is the normal chromosome 9. Here you can see that this long arm, this is short arm. This is a chromosome, normal chromosome 22. This is the BCR. When there is a chromosomal break, so this CML, this BCR ABL, the Philadelphia chromosome, is found on 22. So reciprocal translocation from this ABL and this BCR, then this known as a Philadelphia chromosome. This is again here the C translocation with in this CML. There is a transcription and translation through this BCR ABL fusion protein, and this constitute tyrosine kinase, which can be blocked by the TKI drugs, tyrosine kinase inhibitor drugs, and they reduce the phosphorylation at the multiple subset, and they reduce the apoptosis, and finally they treat the CML. So here the gene transcription, inhibition of apoptosis, excessive proliferation, cytoskeletal organization, degradation of inhibitory proteins. So this is all BCR ABL. After the pathophysiology, come to the symptoms. This is almost asymptomatic in more than 50% of population. So friends, when you will suspect that somebody will have a CML or not? So one, either from the disease suspected from the examination or the routine blood test. 90% the chronic phase. I told you there are three phases. One is the chronic phase, then accelerated phase, and third one is the blast phase. So most patients comes with symptoms of this chronic phase. They are often asymptomatic, and common symptoms are either the anemia, the splenomegaly, routine constitutional symptoms like fatigue, malaise, weight loss, early satiety. You may feel sometimes because of enlargement of spleen. You may have a pain in left upper quadrant, or you may feel something coming out from your abdomen, or something mass is in the abdomen. These are the symptoms. Then physical findings, the most common is splenomegaly in 20 to 70% of CML patients. Hepatomegaly there may be present, lymph nodes also enlarged, and some extramedullary disease like skin or subcutaneous lesion also may be there. Other findings, because of the complication of high tumor burden, or we used to know as a tumor lysis. So there may be a cardiovascular, cerebrovascular, and bleeding. And the other symptoms, pruritus, diarrhea, flushing, they may be present. Now, what you will get in the routine blood picture and the bone marrow. So, 1/3 of patient present with the anemia, and in untreated, the leukocytosis, that is from 10 to 15,000 TLC may be there. The PBF differentially show you the predominance of neutrophils and the presence of band cells, myelocytes, metamyelocyte, promyelocyte, and the blast. If it is less than 5%, then it is a chronic phase. The basophils, eosinophils are frequently increased in these blood pictures. This is the PBF, where this is the normal cell, and these are the CML cells, where you can see the enlarged these band forms. In biochemistry, the LAP score is low, high levels of B12, uric acid, and LDH. Once you will go for a bone marrow finding, then there is an increased ME ratio. That is, normally we know that it is a 3 to 1, but here in the CML, the ME ratio will increase 15 to 20 is to 1. And marrow will show you the blast that may be either slightly elevated, 5% or less, and you will find the basophilia, eosinophilia, and monocytosis during the bone marrow examinations. This is the hyperplastic CML bone marrow. This table is from the Harrison's 20th edition, where these are presenting signs and symptoms of newly diagnosed Philadelphia chromosome positive CML in chronic phase. And as I told you that the age is more than 60, the spleen, hepatomegaly, all we have discussed. Now, after the chronic phase, second is the accelerated phase. The presence of 15% or more peripheral blast. In chronic phase, it was less than 5. Here it is more than 15%, and 30% of blast plus promyelocytes, and 20% are more peripheral basophils present in accelerated phase. And if we see the cytogenetic clonal evaluation, there is an abnormality in addition to the Philadelphia chromosome. And you may find rather the thrombocytosis, here you will find the thrombocytopenia in the accelerated phase. This is the accelerated phase, where you can see these are the band forms, these are the metamyelocytes, promyelocytes in bone marrow. Third one is the blast phase. If more than 20% of blast in the peripheral blood, okay, you need not to go for the bone marrow. If you will aspirate, if you will see the routine PBF, you will see 20% of blast. And because of this blast phase, there may be extramedullary proliferation of these cells also. And there is a large cluster of blast in bone marrow biopsy. As per the WHO, there are two criteria. One is the WHO criteria, and the another one is the European leukemia net classification. So here I discussed about the WHO, where in chronic phase, the blast should be less than 10%, accelerated 10 to 19, and if it is more, then there is a crisis. Basophils, yes, increase in accelerated more than 20% of blood picture. Platelets in chronic phase either may be a normal or increase, but in accelerated phase, you can see the thrombocytopenia occur more common. WBC, of course, if it is a CML, then you will see in both all the phases. Spleen size, of course, if there is a no treatment, then you will see the increased size in all phases. So this is the WHO criteria regarding all three phases. The same thing, the median survival of the chronic phase, accelerated phase, and blast phase. These are the cells which can be seen in the PBF and the bone marrow. Now come to the complications. What complication will have happened? One, I told you that the TLS, the tumor lysis syndrome, and the hyperleukocytosis, thrombocytosis, and the priapism. So when we have to treat this TLS and the hyperleukocytosis, if it is symptomatic or the TLC count is more than 2 lakh, mind it, more than 2 lakh, and the blast cells are more than 50,000. So it is almost more than 25% of blast in the PBF. And how we have to treat this tumor lysis and leukocytosis? We should start.
सर्जरी में कम करता है सर्जरी में एक पेशेंट मिल था जिसका क्रेनियोटॉमी हुआ ADOS के लिए
Mr. Maganraj, please mute yourself. So we have to either give the leukapheresis and the hydroxyurea to treat this TLS. Then the thrombocytosis, when to treat. If it is persistent after the treatment and how to treat, we have to give the anagrelide and the thiotropy for the thrombocytosis. And last, the priapism, the complication. Why it happened? Because there is a mechanical obstruction of the blood vessels by the leukemic cells and coagulation in corpora cavernosa, the thrombocyte because of thrombocytosis, and sometimes because of pressure fields on abdominal veins and nerves because of large spleen. So again, the warm compressions, hydroxyurea, the hydration analgesic will treat this complication. So friends, the examination suspected by the splenomegaly, then see the suspected routine blood, increased leukocytosis, anemia, thrombocytosis, absolute basophilia is a universal finding. So you may not be feel a eosinophilia or something, but basophil will be increased in all CML patients. Absolute monocytosis may be there. After the complication, come to the prognostic factors. So one is the Sokal index, which is the most important prognostic indicators of percentage, how many blasts are circulating in the blood, size of the spleen, and platelet count, age, and cytogenetic clonal evolution. This system was developed based on the chemotherapy treated patients. So in this Sokal and Hasford risk scoring system, this Sokal risk score is included four things: age of patient, the size of the spleen, the platelet counts, how much are there, whether there is a thrombocytopenia or the thrombocytosis, and how many the blast cells in the PBF. And they categorize on the basis of all these, whether it is a low risk category or it is a high risk category. If the count comes at less than 0.8, then it is a low. If it is between 0.8 to 1.2, it is intermediate risk, and more than 1.2 is high risk. Same the Hasford risk factor, where the patient age, size, platelet count. But the fourth one, they have chosen the along the blast cells, they count the eosinophil and basophil also in the PBF. This is a basic difference you can find out in the Sokal risk and the Hasford. So in Hasford, they have included the blast as well as the eosinophil and the basophil in the PBF, peripheral blood film. And the score according to risk category, if it is less than 780, low, between 780 to 480, it is intermediate, and more than 480 is the high risk system, high risk for the CML. Then this is a Sokal index, the risk group, where low, high, low, intermediate, and high, on the basis of whether it is a less than 0.5 or more than 0.5, they have given the survival rate of that patient. So 2-year survival and the median survival of 5 years. So it is, if it is a low risk, then 2-year survival is more than 90%. And the 5-year survival rate is good in low risk, while it is high risk, only 2 to 2.5 years of survival of that patient. Now, how we have to diagnose? Typical findings in blood and bone marrow require detection of the Philadelphia chromosome or its product, the BCR-ABL fusion, the microRNA and the BCR-able protein. It can be done by either the FIS, which we used to known as a fluorescence in situ hybridization. That is a FIS is a process. Then second is the PCR, the polymerase chain reaction. The best one is the PCR. This is the BCR-ABL FIS, where you can see the different colors. There is a this is a normal one, and here this is a the chromosome 922, where you can see green and this orange also, na? So this is a FIS. But PCR, this is a qualitative which allow for the diagnosis of CML. And quantitative PCR is to quantify the amount of disease, how much of the BCR-ABL is present there. And this also allow for the identification of translocations, and it does not require a bone marrow aspirate for the optimal result. So you can do the BCR-ABL via the polymerase chain reaction only on the peripheral blood also. After the diagnosis, the complications, now come to the last part is the treatment. So first we have to treat to control and prolong the chronic phase. Okay. And that can be done by either the TKI, the alpha interferon plus chemotherapy, or the either chemotherapy. And the second motive of our principle should be relieve the symptoms of severe leukocytosis, splenomegaly, and the thrombocytosis. And that can be achieved either by the hydration or the chemotherapy with hydroxyurea and the bus sulfur. The factors which influence the choice of therapy: it is a phase, in which phase patient is presenting, either in the chronic or the accelerated or the blast phase. Second thing is, if there is available of allogenic stem cell transplant donor, yes or no. Then third is the age of that patient. At what age patient presents us. Third, what other medical comorbidities in that particular patient. So all these factors will influence the choice of therapy, that which therapy we have to start in that particular patient. So initial treatment is with the TKI, tyrosine kinase inhibitors, which are the first line in the chronic phase. You should be keep in mind that I will talking about the chronic phase, the first phase. Second, accelerated. Third is the blast. So in chronic phase, we should start with the TKIs, and what they are the imatinib, dasatinib, and the nilotinib. All three agents should be considered as a frontline therapy. The second generation TKIs are the dasatinib or the nilotinib. They produce faster and the deeper response than the first Gleevec, first imatinib. Then the bosutinib, ponatinib. A newer drug, which is a protein synthesis inhibitor, approved by the US FDA for patients who are resistant or intolerant to the 2 or more TKIs. So if we are giving like 2 TKIs and still patient is not controlling, then we have to start the omacitexin, that is protein synthesis inhibitor. And the hematopoietic stem cell transplant, that is the only cure by which we can cure the disease. These are the TKIs. First line, the imatinib, nilotinib, dasatinib. And these are the second line. And 90% achieve complete cytogenic response and response faster with the second line. Median survival is comparable of the normal population. This is table again from the Harrison, where the medical therapeutics in CML. And here we can see that the brands of different the TKIs, and these are the approved indications. So see, the imatinib and dasatinib is the drug which can be used in all phases: chronic, accelerated, and the blast. And the important toxicities of these drugs, either the myelosuppression, pleural, pericardial effusion, and the pulmonary hypertension. The nilotinib, that is Tasigna, which can be used in chronic and the accelerated, but we should not use in the blast phase. Same, the bosutinib can be used in all except the front line. And the nilotinib is associated with diarrhea or arteriocclusive disease, or pancreatitis may be there. So these are the tyrosine kinase inhibitor. The omacitaxin mapsuccinate is used if there is a 2-tyrosine kinase inhibitor already failed. And this important side effect of this Cinribo is myelosuppression. So I am seeing that people are writing in the chat box. So first just see the full presentation, and after that you will not get your answers. Then somebody just write down the treatment of the CML in pregnancy. I am coming on that. So treatment is not completed. Okay. You just write down your questions on your notebook. So that was the chronic phase treatment. Now come to the accelerated and the blast phase. So TKIs, which is preferably second or third generation, are either in alone or in combination with the chemotherapy. I am using word here, the chemotherapy. Will tell you what are the chemotherapy agents, and they reduce your CML burden before undergoing your SCT, stem cell transplantation. Combination, usually the TKI with low intensity chemotherapeutic agents like the low dose cytarabine, edrabicin, decitabine, interferon alpha, and hydroxyurea can be used before the allogenic stem cell transplant. So cure can be done by the transplant, we know. Okay. So it is a curative modality which is associated with the long-term survival rate of 40 to 60% when implemented in the chronic phase. And here you can see in CML phase, use of TKI, the consideration of allogenic stem cell transplantation. These are the general suggestions. So if there is a mutation of T3151, then depends on longer term follow-up. If imatinib failure, then of course third line after second. Clonal evaluation mutation are present, cytogenic response, then of course we should consider the second line as a allogenic stem cell transplant. This is table again taken from the Harrison. Now the response criteria, how we'll see that patient is coming in the remission or not, or patient is giving the response. So there are three things by which we should see whether there is a remission is occurred or not. What are these three? At the level of hematology, then cytogenic, and third one is the molecular remission. So complete hematologic remission where the TLC less than 10,000 and they are normal morphology hemoglobin, platelet should be normal, and the disappearance of your splenomegaly and basophil should be less than 5%. So this is your complete hematologic response. If TLC comes down to 10,000, spleen is okay, basophils are less than 5, means patient is improving or patient is in remission. Second, the cytogenic remission. How we'll see that patient is cytogenetically improving or not? So complete remission means no Philadelphia metaphases is present. Partial, if it is a 1 to 35% Philadelphia metaphase are present, and minor, if it is more than 35% of Philadelphia metaphases are present, in that, then we will see the different type of cytogenetic remissions. Third one is the molecular response. When we'll use to call as a major molecular response, if more than 3 log reduction in BCR-ABL microRNAs, or the ratio of BCR-ABL divided ABL is less than 0.1% by the RT-PCR. That is the international scale. And complete, then again, using the BCR-ABL microRNA using assay with the sensitivity at least 4 to 5 logs below the standardized baselines. So these are the remissions indications by which we can see that patient is going into remission or into the relapse. Now come to the few about the drugs like imatinib. It action of mechanism by inducing apoptosis in cells with the BCR-ABL, and it also blocks the ATP binding sites and preventing a conformational switch to the active form. And specifically for BCR-ABL, the receptor for platelet PDGF, platelet-derived growth factors. Here you can see this is the Gleevec or the imatinib, where you can see that it is a competitive inhibitor of this, and then it will reduce your CML. Here again the same by this imatinib transcription. Here you can see that this BCR-ABL fusion protein, this is inhibited by the imatinib. there is a constitutive tyrosine kinase, then phosphorylation and multiple substrates. Ultimately, there is a reduction in the apoptosis. Yes, there is a resistance to imatinib also. There are 4 mechanisms by we can have a resistance to our first drug in 1990s, that is Gleevec or imatinib. What are these 4 mechanisms? First one is the gene amplification. More BCR-ABLs are produced. So if it is like gene amplification, how we have to overcome this resistance? We have to increase the dose of imatinib. So usually we give it as a 400 OD. Now we have to double the dose. Second one is enhance the expression of multi-drug exporter proteins. And again, the answer to this resistance also, we have to double the dose of imatinib. There are sometimes there is a mutations at the kinase site. If it is a mutation present, then we need not to double the dose, but we have to replace the imatinib with the nilotinib or the dasatinib. And alternatively, signal pathway functionality, the compensating for imatinib, this is a very sensitive mechanism. These are the side effects of oral TKIs, where imatinib is having a bone marrow suppression, fluid retention, diarrhea, skin rash. Same almost for the bone marrow for all dasatinib, bosutinib, nilotinib, and the ponatinib. We should keep the dasatinib and the nilotinib. They can cause the QTC prolongation also. So always we have to take the prior ECG, and after starting this also, then we have to regularly see the ECG. Few words about the allogeneic hematopoietic stem cell transplants. Indication in chronic phase CML, if there is a mutation of T315, if mutation of BCR-ABL that is resistant to the tyrosine kinase inhibitors, and patient who cannot tolerate to any one of the TKI, tyrosine kinase inhibitor drugs. So allogeneic stem cell transplant is no longer recommended as a first-line therapy in chronic phase CML. Once if you find somebody coming with the PBF is showing TLC more than 1 lakh, splenomegaly is there, basophils are there, just think about the CML, go for the phase of that one. Blasts are not there, less than 10%. Think about the chronic phase of CML. This chronic phase can be treated initially with the tyrosine kinase inhibitor. So it can be offered to candidates who are accelerated or the blast crisis only. Chemotherapy currently reserved for rapid lowering of WBCs, reduction of symptoms, reversal of symptomatic splenomegaly. Hydroxyurea can induce rapid disease control, and this cytogenic remission with hydroxyurea is very uncommon. Busulfan also, they act on early progenitor cells as more prolonged effect. The leukapheresis. Intensive apheresis may control the blood counts in chronic phase of CML. It is very expensive, but it is useful in leukostasis related complications like pulmonary failure or the CVAs. It may also have a role in treatment of pregnant women to avoid the potentially teratogenic drugs. Splenectomy, when we should prefer for the splenectomy? This is reserved for the symptomatic relief of painful splenomegaly, which is unresponsive to the imatinib or chemotherapy, or for the significant anemia or the thrombocytopenia associated with hypersplenism. So if all these are present, then we should plan for the splenectomy. And splenic radiation is used rarely to reduce the size of spleen. Rather, choosing the radiation to reduce the size of spleen, we prefer the splenectomy. Now, how we should monitor therapy in CML. Achievement of complete cytogenic response by 12 months of imatinib therapy. Failure to achieve a complete cytogenic response by 12 months or occurrence of a later cytogenetic or the hematological response are considered as a treatment failure. And these are the indications, then we have to change the therapy. Patients who are on the imatinib, they closely monitored until the documentation of complete cytogenetic response every 6 months with PBF, FISH either or the PCR studies. When we should discontinue the TKI and treatment-free remission or molecular cures, there are several studies confirm that the TKI discontinuation among patients who achieve undetectable BCR-APL transcripts for longer than 2 to 3 years can result in treatment-free remission rates of 40 to 60%. If focal risk is very low, less than 0.8, then there is a no evidence of transformation, then also we can discontinue the TKIs. The prognosis before TKI therapy, annual mortality was about 10% in first 2 years, and then it increased 15 to 20%. The median survival time in CML was 3 to 7 years. But without a curative option of allogenic stem cells, the course of CML was toward transformation to and death from accelerated or the blast phase. But after the TKI, now the prognosis is good and course of CML is very good. A few last slide where the special consideration. So if a woman with CML becomes pregnant, we should discontinue the TKI therapy immediately. Then how will control? The control of CML with leukapheresis for severe symptomatic leukocytosis in first trimester, and subsequently we can give the hydroxyurea until the delivery. Approximately 10 to 15% of patients on TKI therapy may develop chromosomal abnormality in the Philadelphia negative cells, and these may involve loss of chromosome Y. There may be a trisomy 8, 20q chromosome 5 or 7 abnormality and the others. And most these abnormality disappears and may be indicative of genetic instability of hematopoietic stem cells. The adverse prognostic factors where the CML will not be treated or will not be cured. If the accelerated phase or blast phase, there is a large spleen, the area of bone damage from growth of leukemia, there is an increased number of basophils and eosinophil in blood samples, very high or very low platelet counts, and age 60 years or the older. So these are the adverse prognostic factors. These are the reference from Harrison Davidson. Thank you so much, everyone, for patience listening. Now we can open for the question answers. Okay. Oh. So in practice, how many years after treatment we'll stop treatment, sir? I just show you when we have to discontinue the tyrosine kinase. If after the 40 to 60%, I'll show you in the last slide. In patient achieving deep molecular response, most reliable predictor for safe treatment free. In most achieving deep molecular response. Predictors for safe treatment. Yes, you should go all see the peripheral blood film with the cytogenetics. You can see whether there's a treatment free or not. CML management in pregnancy. I told you that we should stop as soon as we know that pregnancy is there. Then we should either symptoms are high, then we should go for a leukapheresis. In after this second trimester, we can give the hydroxyurea until the delivery. So the HB target in CML is as normal because there is anemia. So we should keep the normal levels because we have to target the TLC. That should be below 10,000, not the hemoglobin. Patient on TKI should be... No, we need not to go for a bone marrow aspiration. Peripheral blood film is okay.
So CBC would also be helpful. CBC peripheral smear would be helpful. Yeah. So I think most of the questions have been answered by Dr. Daria well, and it was a very informative session on CML. I'd request Dr. Daria to share the slides, share his slides to the group so that people get benefited. And you might be aware that we are heading towards the end of the short certificate courses. So what Dr. Tiwari has requested is an exam for all the people who have joined these short certificate courses. So be prepared for the exams which are coming just around the corner. There would be possibly multiple choice question answers on the e-platform only, and we would be handing out leaflets and these reading materials to all of you at the end of the class, at the end of the short certificate class. So, thank you, Dr. Daria, for
Thank
the
you so much, sir. Thank
wonderful
you.
class and the wonderful presentation that you had. It was an exhaustive, well informative, and well discussed platform. We thank all our participants for being part of this wonderful program called Short Certificate Course, Clinical Hematology. We were extremely obliged to Dr. Sudhir Mehta for conceptualizing this clinical hematology class. Unfortunately, because of his personal issues in the family, he is not with us. But he is seeing the whole class and he's chatting on the group. So we thank sir for your nice introduction of this hematology class, and we also show our allegiance to you in this class. And thanks again to everyone for joining this class. So that is all for today. Thank you very much.
Thank you so much, sir. Thank you.